Good evening, everyone. Welcome to the fourth webinar series of Maha Smiles, Cleft Care for Every Child by Smile Train. I would like to introduce Ms. Shaila Koyana, the Program Director for Smile Train India. Over to you, Shaila ma'am.
Thank you, Shrutika, and good evening and welcome everybody. Smile Train, a bit about Smile Train. Smile Train is the world's largest cleft care NGO. In India, we work with a network of 125 partner hospitals, and we are providing on an average about 36,000 cleft surgeries annually. And I'm proud to say that in almost 25 years of our existence in India, of our work in India, we have provided over 700,000 free cleft surgeries through our partner hospitals. We have been associated with Foxy since 2019, and we greatly appreciate our collaboration with them. And today I would like to just share a bit about our campaign, especially in Maharashtra. This is called the Maha Smiles, Cleft Care for Every Child. This has been made possible through our CSR partnership with Messrs. Bajaj Finserv. And the main aim of this CSR collaboration with Bajaj Finserv is to really build awareness in Maharashtra. And it's for a period of 3 years that we are going to be having this campaign. And we hope that we can provide nearly 8,000 life-transforming cleft surgeries to children in need in Maharashtra. And of course, the major thrust is going to be on creating awareness about the importance of timely treatment and the timelines of cleft treatment. To this end, this webinar series that we are having with EMOGS and Science Integra, we aim that, we will be able to facilitate all the resources that the EMOGS community has about, diagnosis and times of cleft care. We also hope that we can build linkages between the EMOGS members and the Smile Train treatment centers so that children in need and expectant families can really get help, timely help, and they can be referred to our centers in Maharashtra. Currently in Maharashtra, we're working in 10 cities with 11 treatment centers, and you can see in the map, they are spread all over Maharashtra. And we earnestly request all our participants here and all the members of EMOGS that any children who you come across or parents you come across, please refer them to Smile Train India for free treatment. We have our toll-free cleft helpline, which is 1-800-103-8301, or we could be reached through our website, which is www.smiletrainindia.org. I would like to take this opportunity, and I have the privilege of introducing Dr. Sujit Konkar, who's the chairperson of the Fetal Medicine Committee for EMOGS. He's also our moderator today. So without much ado and wasting more time, I would like to hand over to you, Dr. Konkar, to please take the day's proceedings. Thank you so much.
Thank you, Sheila ma'am, for nice words, kind words. Good evening, my dear friends, colleagues, and seniors. We are going to present fourth ECME about cleft lip and cleft palate, jointly organized by EMOGS and Smile Train India and Science Integra. This series has been started to spread awareness about cleft lip and cleft palate amongst all of us. We are greatly thankful to our President, Dr. Rajan Singh Pardesi sir, Secretary Sujata Dave ma'am, President-elect Dr. Kiran Kurtukoti sir, and entire office bearers of EMOGS for giving great support. There is always great help from our convener, Dr. Rashmi Kahar, and coordinator, Dr. Monika Umvardan, for this series. Today we have two eminent speakers. First speaker, Dr. Manisha Ghate ma'am. She will be talking on overview of cleft lip and cleft palate. And second speaker is respected Dr. Srirang Pandit sir. He will be talking on primary surgeries in cleft lip and cleft palate. I invite and welcome our chairpersons today, Dr. Priya Shinde, former secretary, Chandrapur Ubejoy Society. She has been past secretary, Chandrapur Ubejoy Society, co-chairperson, Women's Doctors Wing, IMA Chandrapur, ex-lecturer, Sawangi Medical College, Bardha, Foxy executive member of Food and Drugs and Medical Surgical Equipment Committee and Foxy Clinical Research Committee. She has special interest in infertility and colposcopy. She is member of Bhadravati Shikshan Sanstha, Bhadravati Chandrapur, founder of Shabda Maitri Group, an NGO, arranged many diagnostic and awareness camps in schools, colleges in rural areas around Chandrapur, awarded the Mrs. Signature International Award 2022 for extraordinary contribution in the field of maternal and child health under Rural Health Mission. She is recipient of Foxy Special Prize for exemplary work done for cervical cancer elimination in the year 2021, and she is recipient of Champion Award for public awareness activities for the year 2223 by AMOX. Our next chairperson is Dr. Manisha Vasde. She is Secretary Chandrapur OBGYN Society, past Secretary Chandrapur Women's Wing Committee, member of Foxy PCOS Committee, and she is past Treasurer and Joint Secretary of Chandrapur OBGYN Society. Over to Dr. Priya Shinde for next proceedings.
Thank you very much, Dr. Sujit sir, for kind and elaborate introduction. At the outset, I would like to thank AMOX Society and Dr. Rashmi Kahar madam for inviting me as a chairperson. It's a very nice to know and coordinate with you people like Smile Train, Dr. Sheila Koina madam, who is running the NGO, has given the details of what they are doing. It's creditable. They are doing a fantastic work. And our talk for the today's first session is overview of cleft lip and cleft palate. And for this, we have chairperson, we have speaker with us, Dr. Manisha Ghate madam. I would like to invite and introduce our first speaker. Madam is our president of Chandrapur OBGYN Society for this tenure of 2024. She is very dynamic, multi-talented, and very foxy, very active in Foxy. She is a liaison coordinator of Food, Drug, Medico-Surgical Equipment Committee. She is the chairperson of RTI Committee AMOX. She is the Secretary General of ISOPA Vidhab Chapter. She is chairperson of Women Doctor Wing IMA Chandrapur in year 21-22. She was a secretary. She has held many positions in our IMA as well as Chandrapur OBGYN Society in last. She is active since last 14 to 15 years in our Chandrapur. She is a recipient of National IMA Dr. Kanak Goyal Award for Safe Motherhood. And she is a director of Santaji Mahila Nagrik Sehkari Bank Chandrapur. She has been invited in last few years. She is very, very, very active in Foxy. And she's been speaker in state, national and international conference. And I would like to invite Dr. Manisha Ghate madam for her talk.
Thank you. Thank you so much, Priya, for those kind words of my introduction. Yes, it is almost 5:15 now. So good evening, everyone. At the outset, I would like to thank AMOX, respected Dr. Rajendra Singh Pardeshi, sir, Dr. Sujata Davi, madam, Dr. Rashmi Kahar, and the Smile Train for giving this opportunity to present before you this topic. Yes, and Dr. Sujit Konkar, sir, yes, you are the moderator for this session. Let me share my screen now. Give me a minute. Slideshow is in progress. If you want to perform operation on the slide and the close all. Okay, resume. Yes. Is my screen visible?
Not yet.
No, madam.
Nahi?
Mm-hmm.
Okay, let me see. What has happened? I have just checked.
The green icon is there, no?
हो आहे एक सेकंड ते म्हणतात की आता येत आहे का?
नाही मॅडम. नो मॅडम.
का झालंय? काय प्रॉब्लेम येत असेल आता? खाली परत आले का?
Ma'am, can you just stop sharing the screen and then again try for sharing the screen?
Yes, Shrutika, you please first stop share.
That
Yeah,
way.
ma'am, I have stopped my sharing.
Yeah. You stop your sharing. I will start once more. Have you stopped?
Yes, ma'am. Yes, I have already stopped.
Okay, let me see now. Now it is coming?
नहीं मैडम.
अरे यार, क्या हो गया?
Take your time, Manisha, no problem.
आताच चेक केलं होतं आम्ही. येत होता.
ट्राय रन घेतला होता आताच.
Let me go back.
Shrutika
Step by
can also share.
किंवा टेक्निकल टीम स्टेप बाय स्टेप गाईड करणार तर मला वाटतं लवकर होऊ शकते.
Shrutika can also share the slides.
Yes, ma'am. If you share your slides with me, I will share it on the screen.
Okay. So let me send you. But how can I send you now?
Okay,
मेल
I'll just guide you if that's okay.
Okay.
Yeah. Just come to your Zoom page where this meeting is going on.
Let me try once, Shrutika.
Yeah, sure, ma'am. Sure.
Okay.
येस हां.
Yes, it is visible now, ma'am.
येस मॅडम विजिबल.
पण मला आता जावं लागेल ना.
आता
नाही
मॅम
पण
फक्त PPT ओपन करायची आहे तुम्हाला.
हो ग, पण ते कुठे गेलंय तेच बघते आम्ही. सगळ्या याच्यामध्ये. I'm stop sharing. I will let me go towards my. Can you take the next lecture if you want? Yes, anyone? Speakers आले आहेत का दुसरे? Rashmi?
Dr. Sriram Pandit sir has joined.
Yes, then you can proceed with sirs. I will talk with Shrutika and send her the mail. कारण इकडनं होत नाहीये माझं PPT पाठवते मी तिला मेलवर. चालेल?
हो श्रुतिकाला जर आता पाठवता येत असेल तर आपण टॉक सुरू करू शकतो.
हो, एक सेकंड.
मला पाठव, मी श्रुतिकाला पाठवते असं.
चालेल, एक सेकंड.
Welcome, sir.
Good evening, sir. Pandit sir, good evening.
Hello.
Good evening, sir.
May I introduce, sir? I've joined.
ना टाइम आहे. मनीषा.
हाँ मैडम.
मैच स्टिल गोइंग ऑन मनीषा.
हाँ मैं ग्राउंड में हूँ पर आई एम देयर. आई हैव लॉग्ड इन नाउ.
ओके.
अरे वो अपनी टीम खेल रही ना, बैटिंग शुरू है अपनी टीम की.
वाओ. सम टेक्निकल इश्यूज गोइंग ऑन. मनीषा घाटे मैडम लेक्चर करणार आहे.
अच्छा शुरू करते हैं का मैडम? ओके. अच्छा.
You want me to start?
Yes, sir.
Yes, sir, please start.
Yes, sir, you can start. Rashmi, I have sent you the mail.
Yes, I will.
Have we introduced, sir?
Yeah. Dr. Manisha
Yes,
will
yes.
introduce Pandit sir.
Yes, sir. Can I have the CV of sir?
Shrutika, please post the CV.
So, good evening, one and all. So, today we have with us Dr. Srirang Pandit, sir. Sir has done his MBBS in GMC at JJ Hospital. Sir has done his MS surgery at Mumbai. He's a plastic surgeon at St. GS Medical College. He's a past president of Maharashtra State Chapter and founder member of past president of Pune Association of Plastic Surgeons, executive trustee of Maha Association of Plastic Surgeons, professor of plastic surgery at Bharati Vidyapit Medical College, Sancheti Institute for Orthopedic and Rehabilitation since 1996, registrar plastic surgery at JJ Hospital, Ethicon visiting professor in cosmetic surgery, full life member Association of Plastic Surgeons of India, life member of Association of Surgeons of India, ASI, life member of Burns Association of India, founder member, life member of Pune Association of Plastic Surgeons, founder member of Indian Association of Cosmetic Laser Surgeons, life member of Indian Association of Aesthetic Plastic Surgeons. So with this, I introduce Dr. Shrirang Pandit, sir. Over to you, sir.
Thank you. Good evening. Can you see my screen now?
Yes, sir.
Yes, sir, your screen is visible. Yeah.
Good. Thank you so much. It's a real pleasure to be with colleagues who are interested in treating facial clefts. I must say that I did my first cleft lip surgery in 1977. So now this is close to 46 years since I'm doing cleft surgeries, and I would like to give you a short perspective of how the treatments of cleft lip and palate run. Well, first and foremost, I bring you the greetings from Pune Hospital and Research Center, where we have our Smile Train Center located since 2002. So we have been with Smile Train for 2002, that's almost 22 years now. And we have done nearly 10,000 surgeries over these 20 years. It has been a great experience, and I consider it a privilege to have had the opportunity to treat so many patients on whose faces I have been able to restore smiles. Me and my whole team seeks your blessings for our young special children. They need the blessings because there are so many things that you can do for them. And if you have good support, you can take the treatments way, way high. That's me. You have seen the picture. So what you must understand is cleft lip palate is a very multifaceted and complex deformity that evolves with time. The face of the child changes, and like nobody knows how the child is going to look when the child is born. The face keeps changing, and as it changes, what happens is the features change, the development changes, and that will change the way we look at the children. And at times, we have to work with the children for their entire adult life till they are 21, 22, 23 years old. And I've had hundreds and hundreds of patients whom I have operated when in 86, 87, 88. And they're coming to us for final treatments, which run into almost 20, 22 years' time. To do this, you must have a very strong and dedicated team to see them through this long ordeal of surgeries. So this is my team, my very esteemed and very competent, powerful colleagues, Dr. Gandhi, myself, and my son, Dr. Vikram Pandit. We have been doing all this work at Pune Hospital since long time. This is our outpatient department where we see patients, and a beautifully set up operating room where we have almost all gadgets, all equipment that is necessary to keep this and treat these complex patients. I must thank my anesthetic colleagues on whose shoulders we stand and produce the results that we have been able to get. She is Dr. Mrs. Thatte. She has been one of our pioneer and a very strong support in the anesthesia department. And here is Dr. Sandeep Mutha, who is also a very competent and good pediatric anesthetist. And you can see his commitment. He is carrying the child with a cleft lip. And you can see that on his face, there is the child is so quiet. So you can see the kind of relationship the anesthetist has with the baby, which is so young, and it is giving a good, nice smile. And this is the same child after it has been repaired a few months later. And you can see the beautiful lip that you can create if you do it in good time. So a good anesthetist is a very important part of the Cleft team. The anomaly scan has revolutionized the diagnosis of facial clefts. And the diagnosis of facial clefts has become more simpler and easier because of the advent of the scans. And these are the scans which show how the baby with cleft lip and palate looks like intrauterine. And these are some images which I have taken from the net to show you the way the changes occur in a baby which is with facial clefts. So now what has happened is either the ultrasonologist or the gynecologist is the first medical professional breaking the news to the anxious parents. And now we have many people, many young women, many young girls who are having first time pregnant. They come to us and ask that our baby has got this, which is diagnosed anomaly scan, and what should be done for these babies. We tell them that it is a perfectly treatable deformity. And if you have time and patience, you will be able to have a nice, healthy child, which will grow into a normal and functional human being. So prevalence of facial clefts is reported at somewhere around 6 per 1,000 live births. And just to give you a spectrum of patients that we see, these are the children with facial clefts. One side is a right-sided cleft, other is a left-sided cleft. The left-sided one also has a cleft palate, while the right side has got only an incomplete cleft lip. This is another very aggressive deformity. It's a bilateral cleft lip and palate deformity. And you can see where the maxilla is. The premaxilla is just under the tip of the nose, and the lip is practically horizontal to the floor. Another deformity, this is a bilateral cleft lip with palate, and this is how it looks immediately after the surgery has been performed. You must understand that this repair that you produce because of gives a very dramatic and very interesting change in the features of the baby. So this is another patient. It's a unilateral cleft lip, and this is the picture immediately after doing this surgery. And you can see we have tried to match as much as possible what God has created onto the right side. We have one side for reference, so we know what to do on the other side. And doing these kind of procedures is a really rewarding result. You can have very bad clefts. This is a girl who has got clefts practically everywhere. There's a cleft in eyebrow, cleft in upper lid, cleft in lower lid, cleft in the cheek. And also she has got a very bad bilateral cleft of the palate. So she has had so many clefts onto her face. And if you see her post-operative picture, this is how she looks like. On the left, if you see, that is her smile. She is trying to smile. And because the central part of the face is not connected with the rest of the face, you can see there is no animation on the nose. There is no movement in the upper lip, but the rest of the face has gone into a kind of a twist. And if you see her on the right side, we had repaired 8 of her clefts in one go. In one operation, we have finished so much of work for her. We had asked her to come back again for follow-up, but she hasn't come back. But this is how she looks smiling now, a much, much happier child than what she started with. You can have clefts which are like this, and it's one of the another gruesome clefts. We can see the clefting everywhere. The eyelids are cleft, the nose is cleft, there is bilateral cleft lip and palate, and a real gross deformity. And in this child, in spite of being very small, we went ahead and did almost practically correction of all clefts except the palate. And this is how the child looks on the operation table as soon as we finish the procedure. These have to be done in time, because if the mother sees this child for a long, long time, it's a real major psychological depressing factor for her to bring up the child. The clefts can be at many places. The cleft can be on the nose. And this is how the cleft is treated and repaired. And you can have a nice, pleasing result after the repair. You can see the nose is corrected almost to normalcy. There is a scar on the nose. It will get better with time, but you can produce a good result from these procedures. This is a median cleft, again, completely treatable. This was a young boy who had come to us in the childhood. And now after correcting, it's a 23-year-old follow-up. And you can see how he has improved after the treatment has been completed. You can have a cleft like a proboscis when one's nostril is absent and it looks like it's like a trunk of an elephant. So it's called as proboscis. So this is a typical cleft lip and palate deformity where you have a severe nasal deformity. There is a disparity between the alveolar gap and the lip also is cleft. So the diagnosis of cleft lip is very obvious. The moment you look at the child, you know that the patient has got a cleft. The parents know that the child has got a cleft lip. The palate can be missed sometimes if a good look inside the mouth has not been performed. So the most logical question the patient asks immediately afterwards is, when are you going to operate? Where are you going to operate? And how much it is going to cost? Smile Train has eliminated the cost equation pretty effectively. We have some powerful donors which work with us. There is Mr. Bajaj Finserv, and he has been very gracious in granting us a lot of financial help to keep this program running smoothly. Their corporate responsibility is very much on their mind, and they do care for these patients with clefts. He has recently introduced the concept of doing cleft Mukt Maharashtra, and I think we can take it further with his help. They're also very encouraging. When we finished 5,000 surgeries, they held a small program for us to felicitate all the members of our team. I must say that Pune Hospital has been very, very helpful to us in supporting this venture all throughout, and at no point of time we have ever had any difficulty with running the program. So normally the full-blown cleft lip and palate will require multiple surgical interventions. The repair of the cleft lip is one of the most dramatic surgical transformations that you can see. It is critically important to understand that cleft lip repair is not just plugging a hole. If you look at the lip of a normal child and the lip of a cleft child, you will see the kind of anatomical differences that exist, and to recreate them is more art than science. It's a 45-minute procedure, and if well executed, transform the life of the baby and the family in more ways than one. The mother generally who feels guilty and responsible for the cleft is relieved of the immense psychological stress and is justifiably overjoyed. It stands to logic that the earlier you repair, the better it will be. Then why wait for 3 to 4 months? There has been attempts at doing intrauterine repair. The baby was taken out for a short while, the lip was repaired, the baby was put back into the uterus, and the baby was delivered cesarean section later on. The repairs didn't do very well. The only logic was that the repair will be a scarless repair. But the alignments were very poor. The risk of anesthesia was very, very significantly high, and the mortality was very, very high. So the repair has been abandoned and nobody does them anymore. The anesthesia, they said, is very risky. The tissue demarcation is not very clear in the vermilion borders, and the repair generally has a lot of malalignment problems. At 4 months, the anesthesia is much safer as the child has grown a little more, and post-operative care is also easier. The aims of lip repair is to restore the aesthetic and functional near normalcy. It also helps the dental alignment because the lip acts as a sling to keep the growth of the teeth and maxilla in control. It also aims at accurate restoration of the function and aesthetics. What we produce must look good and also must work well. So the lip acts as a restraint to model the maxillary growth. The lip repair is generally timed at about 3 to 4 months of age. 10 grams of hemoglobin, 4 to 5 kilograms of weight, no respiratory infections, and a thriving healthy baby is what we need to go ahead with the lip repair. The golden rule of 10 is still very, very valid. 10 grams of hemoglobin, 10 weeks of age, and 10 pounds of weight is what is considered mandatory for a lip repair. What you need is an experienced surgeon, an anesthesiologist who is particularly deft at cleft anesthesia. The anesthesia with clefts is a completely different ballgame. And unless you have a good anesthetist, it is not very easy to intubate these children and do the procedure safely. Well-equipped operating room is absolutely must, and a good post-operative care is the part of the treatment. What happens is during surgery, the oral cavity is involved, so we are sharing the airway with the anesthetist. And if you do not take good post-operative care, the catastrophic complications and even fatalities can occur. Normally, the child is started on oral feeds when it is wide awake or by the time of 2 hours. First few feeds are done under supervision of a trained nurse. The intermittent venous line is kept in place for 24 hours, though IV fluids are not required. Blood loss in a well-executed lip repair is to the tune of 5 to 10 ml. The child is nursed in the ward for 24 hours after surgery and then is discharged the next day morning. The commonly used suture material is 4-0-Vicryl and ethylone 6-0. It permits the parents to wash the face very easily because it's a nylon suture and food doesn't stick to it. And keeping the baby clean is very, very easy. The sutures are taken off in a week's time. Normally, no anesthesia is administered during that time. The impact of both physical and psychological of the lip repair is awesome. And if you see a child like this, you can see the kind of improvement that you can produce in the child. You can see that the symmetry is very well achieved. The cupid's bow of the lip is looking very good. There is a nice central tubercle, and it can pass off as one of the top class cleft repairs at all times. Another baby with a severe bilateral cleft lip and palate deformity. This is after she is 9 years old. She has gone through multiple procedures, but if you start the treatment in time, generally your results will be very, very satisfactory. Now, you will see a series of patients, the way they have so another cleft lip here, another cleft lip here, and all of them do very well with a good cleft lip repair. So this is a child with a cleft palate now. Coming to the cleft palate, you can see there is a big wide separation in the cleft. It's about more than a centimeter of gap in the cleft. This is another palate being operated in a small child. This is generally the second surgery that is done in the first year of life. The 10 months to 18 months is the optimum time for cleft palate repair. The child starts making sounds by the age of 10 months, and hence the speech apparatus should be repaired by that time. So that is the logic of getting the repair between 10 to 18 months of age. It is proven that the speech outcomes deteriorate if surgery is delayed beyond 18 months, as children develop faulty articulation. Cleft palate repair is a much more involved procedure. It separates the nasal cavity from oral cavity. It facilitates speech and prevents food from entering the nose. So this is a typical cleft lip palate repair done. It takes about 1 hour, 10 minutes, and you can do a nice repair, close the gap completely. You can see the incisions which are taken laterally, and that's how the palatal shelves are moved medially so that the repair is complete. The blood loss can be up to 20 ml, which the child can bear very easily without any difficulty. It is now proven that the repairing the muscles of the palate, like the tensor villi palatini, is very important to create a good speech outcome. So this is the muscle you can see on the left picture, that the muscle has been dissected and it is repaired in midline with each other, and a nice chunky muscle sling is produced there, and the lip palate repair is complete. A palate repair needs more post-op monitoring due to the possible bleeding in the oral cavity and respiratory embarrassment. The children are normally kept in recovery for up to 4 hours till they are fully wide awake. There is no bleeding. They accept a couple of feeds and then they go back to the ward so that they can be looked after more easily with less problems. Rice tube feeding is never required. I haven't done it ever once in my life. And they start taking feeds orally easily and continue further with that. There is a condition called as Pierre-Robin syndrome, where sometimes you have microgenia and cleft palate. And in such patients, because of a very small chin, intubation can be extremely difficult. And at times we have to abandon the procedure till the child grows up more. This surgical exercise is only possible if the children are well nourished, healthy, free of respiratory infections. nutrition plays a very major role. And here the pediatricians can help us a lot. And now even the Bajaj Group is starting a nutritional program, which should be very helpful to our children. So these are the patients and these are the smiles that we try to look at. And with the help of Smile Train program, we have been able to produce many, many such smiles. And a healthy, cheerful, and laughing baby is the aim of our program. And that's the aim that we want to follow, to make them look nice and feel good and be normal children. So the aim of our whole program is a happy mother and a happy child. Thank you so much.
Thank you so much, sir, for such a wonderful input from your side. And plastic surgery is such a boon, I must say. And it was a very good input. Thank you so much, sir.
Thank you. Thank you.
Over to Rashmi ma'am.
Thank you, dear Manisha ma'am, for taking time out of your busy schedule and from ground.
Sorry, ma'am, I couldn't give you much time just because we had the matches. Yeah.
Really very much thankful to you.
Thank you.
To Pandit sir, it was really a very good talk, and all the insights into such a complicated procedure were a real, learning experience for us today.
Yeah, and
Thank
also
you so
you have
much.
shown
Thank you.
various types, different rare types of clefts, so that we have not seen in our practice. You see only cleft lip and cleft palate. Those plates of face and involving all those orbits. These are rare to see for
There are
us.
23 types of cleft that you see in the face.
Yes, sir. I was also seeing for the first time the rarest
Yeah.
form of orbital
Clefts.
Yeah, it is very rare.
You are doing great work
Yes, sir.
in the restoration of smiles of these innocent babies. So it was.
Thank you so much. It's a privilege. I consider it a privilege to be able to treat these children. And it's possibly some energy working through my hands to help them.
Thank you, sir.
Thank you.
Now let us start Manisha Ghate ma'am's lecture.
Yes.
Okay.
And sorry for that technical glitches from my side. Okay. Shrutika, can you play the... Yes. So we are going to talk on the topic cleft lip and cleft palate and overview look for this topic. Can we have the slide? Yes. This cleft lip and cleft palate. They are the most common congenital anomaly occurring at the orofacial region. It may be isolated cleft lip or palate, or maybe in combination both. Then the treatment at right age and at right time, it is the cornerstone of the treatment. And multidisciplinary, interdisciplinary, and the coordinate care is required for this babies to get cured from this cleft lip or cleft palate. So to introduction, this cleft lip, it forms due to the failure of the fusion of frontonasal and the maxillary processes. It results in cleft lip either through the lip or the alveolar or the nasal flow. And regarding the cleft palate, failure of fusion of the palatal shells of the maxillary process occur, which results in the cleft in the hard or the soft palate. And this occurs during mainly the fourth development stage of the fetal life. It appears when the location of the failure of fusion occurs in the embryonic life when there is interference with the development. Next slide. We all know that frontonasal prominences, they develop into the medial and the lateral nasal prominences. So what happens to maxillary prominence? They grow towards the natal prominence and they create a nasolabial region and the lip. This occurs in the normal development. If this fusion is failed around the 5 weeks of the intraembryonic life, then it leads to the formation of cleft lip. Next slide. So, regarding the morphology of the face, 5 fundamental facial prominences are there. The primordial mouth, which develops at around 4 weeks of gestation. Then the frontonasal prominences, two bilateral maxillary prominences and the two bilateral mandibular prominences. So what happens? This frontonasal prominence, it develops into the medial and lateral nasal prominences. And these two maxillary prominences, they grow towards the nasal prominence and they create a nasolabial region and the lip. And we know that this fusion, if failed around 5 weeks, they leads to formation of cleft lip. Next. At the same time also, the development of the palate begins and it is completed around the 12th week. Now what happens? The median nasal prominences fuse in the midline to form the primary palate. This is the normal development. Then this medial side of the maxillary process, they rotate and develop into the lateral palatine processes and fuse in the midline to form the secondary palate. But if there is a failure of this midline fusion, it leads to the formation of cleft palate. So this is the picture of complete cleft palate before the repair, before the surgery. And this is the picture of cleft of the soft palate only. We can appreciate it. So now with the new diagnostic tools and the very good resolution of our sonography machine, at the present, we can diagnose most of the cases of this cleft lip and cleft palate in the intrauterine, right? When we are doing especially the anomaly scan. The equal sign, which was published as a novel marker in the diagnosis of fetal isolated cleft palate by William and Borges, have helped much for diagnosing these deformities. Next slide. Yes, we can very well appreciate from these slides the deformities seen. You can easily see. Next. Yes. This again, you can appreciate the deformities in these pictures of cleft lip and cleft palate. Both you can see. So, talking about the incidences, we get isolated cleft lip in around 15% and isolated palate around in 40%. But the combination of cleft lip and cleft palate, we have around 45% of the incidences. Next, the causative agent, we can say that it is a syndromic or a non-syndromic type, or maybe due to a single gene mutation, but many a time we don't get any unidentified causes for this formation of cleft lip and cleft palate. Now going to the non-genetic causes, yes, smoking, alcohol, stress, chemical exposure to certain substances, advanced age of the mother, diabetes mellitus, and the exposure of the fetus during the intrauterine life, mainly like the drugs like anti-epileptic, like valproic acid, phenytoin, then retinoic acid, etc., they can lead to the formation of this deformity. Now, what are the clinical features of these babies? So, they have mainly the feeding problems in the neonate. They don't get weight gain. So, failure to thrive is the second most serious problem in this baby. Then they have a lot of speech problems if it is not repaired at the particular age or particular period. Then hearing problems can also occur and dental problems can also occur to these babies. So now let us talk about the management. Pandit sir has very much emphasized about the management of these babies and the time required for their proper operative surgeries to get rid of these deformities is the mainstay of the treatment. That if we are planning early during this period, and we get a fantastic and wonderful result. So the education to the parents is very much important regarding the management. Then counseling of the parents, treatment at right age and right time is very much important. And the psychosocial rehabilitation of these children along with their parents is also the mainstay of the treatment. So I will emphasize that cleft lip repair, it may require 1 or 2 surgeries, as sir has very well stated, and is usually done between the 3 to 6 months of the age. See, several techniques like lip tapping regime, nasal elevator, nasal alveolar molding, that is them, may be required for these babies. And cleft palate surgeries are mostly done within a year of infant's life. Some may require additional surgeries for the cosmetic repair. So, a multidisciplinary approach is required to take care of these affected babies. A whole team, right from the neonatologist, orthodontist, plastic surgeon, ENT surgeon, speech therapist, psychotherapist, and of course, the emotional, social, and tender loving care support from the family is very, very much required for bringing a confident and a happy smile on the faces of these children. So let us join hands together to bring smile on the faces of our affected children. Yes. And next slide. And this smile train continues. Thank you for giving me the opportunity. Thank you.
Very nice talk, Dr. Manisha Ghatte, madam. And I must say, this theoretical lecture after practical, it's technical glitch. Otherwise, also we have seen the pictures first and then the theory, so we can connect with it very, very well.
Yes.
Because sir has given so nice explanation of how the surgery is performed, how is the team. We got all the practical information, and then you sensitize us with the how much is the incidence, how we have to be very much aware during our intrauterine care of our patients. And you have covered everything, I must say. And sir is doing a very credible work. He's doing since 46 years.
Yes.
It's like my age he's working with. He has done
Yes.
more than 10,000 surgeries. Hats off to the sir also, to the Smile team. And congratulations to the team of the sir. And AMOX committee has given a very nice, sensitized us with this, what they are doing since so long. Very, very good. Thank you.
Thank you, Dr. Priya. Are there any questions, Srutika?
No, sir.
Sir said it's
Yeah.
surgery has been done after 4 months, and we can do till the age of 18 years, no?
Yes.
It's like that only.
Yes,
After
but-
4 months.
Yes, but if we do on this particular age now, the results are very good because what these children have now, they say that they get ear infection repeatedly and all these things. Again, the speech problems come if we don't get the cleft lip and palate don't get repaired at a particular age. Okay, so the
Minimum
time
age is
is
4
very
months.
much important for their developmental milestone. So we have
Yes,
to
ma'am.
take care of that.
Yes, ma'am.
Thank you, Manisha Tai. Thank you, Priya. Actually, I must say that the shuffling of the talks had more impact today's webinar.
Yes.
Yes.
Actually, it happened.
Yes, yes. I also am thinking like that only now.
Thank you so much. And Manisha Tai can definitely add more inputs because having a surgeon in home adds more knowledge to the webinar and everything. That's an added factor here.
Yes.
Actually, regarding this etiology, I would like to talk because I have seen that it has a genetic predominance also in most of the cases. If one child is born with the cleft lip or palate, there are chances that the second baby is also going to have get affected with the same. This I want to stress. So when the patient comes to us, so we have to be alert and rethink about when she comes again for the antenatal checkup towards us. This is the where we can help her to get out by proper doing the anomaly scan and get to see that if this baby is also not carrying this same problem or not. That would be my take home.
Yeah, at this stage, like consultants like Dr. Sujit Konkar sir can be of great help to us.
Yes.
In antenatal diagnosis of such complicated conditions.
Yes, sir.
Yeah.
Can you throw light on the fetal medicine aspect of this?
Yeah, there was a in first series, first webinar of this series was dedicated to the imaging only.
Okay.
Stop imaging in cleft lip and cleft palate, because imaging of cleft lip is easy, quite easy, but diagnosis of isolated cleft palate is quite difficult. It requires some additional views. Like you need to have extended. You see that uvula equal to sign of uvula seen, that is like screening. If you don't see equal sign, you don't jump into diagnosis of cleft as well cleft palate. You have to look the baby in extended position. Neck should be extended like this, and you can see if there is some fluid in the pharynx, then that equal to sign seen in that position confirms that there is no isolated cleft palate. That is the basic thing in imaging, and this is especially advocated when there is pregnancy is high risk. That means if elder brother or sister sibling is having cleft lip palate, or someone in family is having this issue.
Can I ask a question?
Yeah. Yes, sir.
So,
Yeah, the problem is when they have one child which is with cleft and they ask whether they should take a chance with the second child. That is the time giving the advice becomes most difficult, because there is no way you can assure or guarantee that what kind of child they will have.
Yes.
And once they have gone through this series of surgeries and the physical and mental agony that associates with looking after children with facial clefts, for them it is something they're really worried whether if the second child comes with a similar deformity. They say that we don't want to have another child for that particular reason. So what should be the advice to them?
We can keep the sir, can we keep the option of MTP to them for such cases? If it is a mild,
Normally it is not
one, it's
diagnosed so
okay.
early. Normally diagnosis comes a
There
little
is
later.
now a new concept of mini scan, which can be done early in the pregnancy.
Around 13-14 weeks we can diagnose.
18 to 20. Mini scan, yes, we can identify. If we are having a good resolution of
With the advent of new machines, very
Yes.
good resolution, you can diagnose around
Yes.
13-14 weeks.
Yes.
See,
And then we can give the option to the patient.
the reason I am asking this is in African communities, they had a practice that every single child born with deformity is to be killed on spot.
Oh.
And it has been running, I think it is still on probably. The whole idea was not to propagate the gene which is defective. And we always thought that that's a barbaric way of doing it. But if you diagnose a, say, fetus with a cleft at 14 weeks, 15 weeks, and then whether you will ask them to terminate or whether you ask to continue, that has always been something which has bothered me. I am never comfortable giving advice in such situations.
nowadays, but if the patient is antenatally diagnosed with having this disorder, and we provide her good counseling, so the chances of continuation of pregnancies have been observed. There are more in those patients who have been very well.
I have had only 2 occasions in last 50 years where somebody terminated the pregnancy knowing that it's a cleft lip baby.
Yes.
The only thing is they have to live with a long, I mean, it's 20 years it takes for the cleft child to of looking after multiple surgeries, getting in an hospital out. And though they look quite nice and good, everything is fine. They do. 2 of my patients have become plastic surgeons now. One is practicing in Australia and another one is in US. They're excellent. I mean, as far as human beings, they're great. They're fine. But what you tell them when they are in infancy or they are 12 weeks old. So that is, I mean, I can't really honestly tell you that I can be, this is the ideal advice for them. Because one patient I had faced was an extremely beautiful woman, the mother. She was so good looking. I mean, one of the probably rare beauties. And she had a baby with a bilateral cleft lip and palate. The child was extremely, I mean, you know how a bilateral cleft lip and palate looks with a projecting premaxilla. And that is the only one person whom I am sure she let her baby die after it was born. But there was only one instance. Most of the parents are extremely loving and they take very good care of them. So sometimes you are in a dilemma, how to go about it.
Yeah, really.
Yeah. And you can't really deny them that it's not easy. 20 years looking after the baby is not easy. I mean, whatever we say and do, whatever help you get from whatever sources and this, still you have to, I mean, ultimately the baby has to lie down on the table for surgery. So that has been something which I wanted to ask in this interaction as to
Yeah.
what kind of counseling will be, because they don't mind not having another baby, but whether when they want to have a baby, then what to expect. I mean, none of their families ever had any clefts. So the chances are less, but they are less, not ruled out.
But thankfully now we have Smile Train associations like NGOs like Smile Train.
Absolutely. It has been a
And,
real boon. Real boon.
competent plastic surgeons like you, sir, and antenatal diagnostic modalities we have competent
Yes,
people.
yes,
So,
absolutely, absolutely.
and we are more aware. We can have patients get this more psychosocial rehabilitation and counseling. And I think
Yes, yes. And there are a lot of self-help groups which are in cleft lip community, and they also help the children to grow better.
Definitely.
wish-
And then I'd like to add that there are surgeons like you, Dr. Pandit. So I don't think anybody should be really scared. Yes. So I agree with Dr. Rashmi that, counseling and promise of care and availability of facilities should totally deter parents from,
Yeah,
having an
Yes, we
MPP.
have the proper counseling in the antenatal period now
Yes.
itself
Yes.
works, because my one infertility patient, she conceived and she was having the baby with cleft lips. So they were not much happy with that type of report. But after proper counseling, when she delivered, she had followed all my instruction, and the proper treatment they have received, and the baby now comes to meet me with that so graceful smile. ना I am very happy की
yes.
चला म्हणजे जर आपण प्रॉपर काउन्सिलिंग केलं सर, पेशंट एक्सेप्ट करतात. येस, देर इज अ we have to
Today
give them a
morning,
chance.
Today
Yes.
morning, I saw twin bilateral cleft lip and palate babies,
Yes.
both diagnosed, intrauterine.
हाँ.
At 5 months, they were diagnosed as twin bilateral cleft lip and palate.
Yes.
And now they will start surgery on them from next week. But twins, and the mother kept both of them in the sense that she didn't go for terminating the pregnancy. And they're nice, healthy babies, and we'll try to make them as good as we can.
Yes.
Yeah.
It's definitely
Counseling,
the
you can just show
condition
the
and
pre-op and post-op photos of Sir Pandit Sir's library, just shown in his talk. It will be very easy to counsel them.
Yeah, we do it all the time.
Yeah.
Because that is something which tells them that they are
It's
not
visual
alone.
impression, no? Direct.
They are not alone. There are so many like them.
Yeah.
Yes. Yes.
Because otherwise, the fear that I am the only one affected, it grows on your mind over a period of time. And
Of
once they
course.
see in the OPD there are 20 people with clefts, then they say it's okay. It's not something very bad.
Yes. Right.
so
Yes.
that's with the help of Smile Train, we are actually propagating this awareness all over the Maharashtra.
Absolutely, absolutely. He's
Yes.
done a great job, and we are so happy. But two things: one is every surgery doesn't go smoothly. There are some problems. There are breakdowns. There are fistulas, and at no point of time they have stopped us from doing the best. In the sense, I repaired one palate 3 times, but I was never asked a question: why are you operating on the same baby 3 times? If I say that's a fistula which needs to be closed, they have never held back the help to the child at any point of time. To me, it's one of the greatest advantage to a surgeon is to be able to rectify a mistake. Because that chance I will always want, because I control a very small part of the whole treatment part. Healing is by so many means. We all know, we are all surgeons, so we know we only stitch the wound, the God heals it. So great to be a part of this program. Thank you so much.
Thank you, sir.
Thank you. Thank you so much.
Now, coming to last part of this webinar, vote of thanks. Anyone has to say anything? Any comment? Yeah, I'm very much glad to deliver the vote of thanks on this occasion. Very sincere thanks to our speakers today, Dr. Manisha Ghate ma'am and respected Pandit sir, who have enlightened us with their great knowledge. Thank you, Shaila ma'am, for your introductory talk. Many thanks to our chairpersons, Dr. Priya and Dr. Manisha, who have commented very nicely and discussed the issues very well. Great thanks to our convener, Dr. Rashmi, coordinator, Dr. Monica, for this program. Big thanks to Science Integra, who is always helpful in this series. Great thanks to Smile Train. We all of us are working to your goal only. And any webinar is not successful without the involvement of audience. So a big thanks to all delegates who have joined in, logged in for this webinar. Thank you. Thank you.